Welcome to the QAPI journey. Are we there yet? Conference call. My name is Victoria, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct question and answer sessions. Please note that this conference is being recorded. And now I'll turn the call over to Sheila McLean. Sheila, you may begin.
Thank you, Victoria. And good afternoon. As Victoria introduced me, my name is Sheila McLean, and I am Program Director with QAPI. And joining me today are Improvement Consultants Linda Harris and Teresa Mandela. I'm going to pause for just a moment for just a little bit of housekeeping details. As we're presenting today, if you could just remember to keep your phone lines on mute. And then what we'll do is at the end of the call today, we will help you to unmute your lines so that you can actually ask any questions or comments. And also, we ask that during our time together that you participate, that you are attentive and engaged, that you're open and collaborative. And to do that, we also ask that you use chat. You will notice your chat box is on the right-hand side of your screen. You may have to open that. There's a little arrow kind of in the middle of, I'm sorry, I said the left hand of your screen. I need to learn my left from my right. The right hand of your screen is a little arrow that says chat. You can click that arrow and that will open up your chat box. Or also at the top right of the screen, you'll see a little icon that says chat. So either of those icons can open the chat box for you. And during the presentation today, Teresa Mandela, one of the HQC's improvement consultants, is going to actually be monitoring chat for us, and we'll be posing some questions for your input. So we also remind you to please take a moment before leaving the event to complete the evaluation that we will open at the end of our time together. Your feedback is important, and we certainly appreciate it. So knowing the housekeeping detail, I'm not going to stay on this slide long because you can certainly reference this in your handout. But we always like to provide you with a library of our past events. These listings of previous events can be found on our online community, and they are recordings of these events. So if you see one that you missed, please feel free to join our online community and access, or also you can share this and use this as education for your team members. So getting started with our purpose today. So during our time together today, we're going to learn how to set and utilize performance measures. And also, I want to take this opportunity today to share with you an update about how we're doing, how we're progressing as a collective team in the Maryland and Virginia Nursing Home Improvement Network. We also want to recognize and celebrate some of our network participants' performance. And then the last part of our presentation, you will be hearing from some other nursing facilities about their best practices and lessons learned for implementing a systematic approach to measuring and sustaining quality improvement efforts. So we have a full agenda. So to get us started, I just wanted to set the stage and review the definition of QAPI. So as we can see here, and as we all know, it's two parts. We have the quality assurance part, which is an internal review process that audits the quality of care delivered and implements corrective actions to remedy any deficient practices. QA tends to be reactive, whereas performance improvement is proactive. It focuses on systems rather than individuals' performance and seeks to improve quality rather than correcting errors when thresholds are crossed. Performance improvement means making things better, not just fixing fires or managing crises. It also means setting aside the customary practice of blaming people for problems or failures. It's a way of looking at how can we do our work better. And together, QAPI is a data-driven and proactive approach, and it's designed to involve all members of the organization to continuously seek opportunities for improvement, to address gaps in systems through planned interventions, And really, we need to think about QI as the way we do our work. And we will hear that from some of our nursing facilities that are going to present later today. QAPI is not a program. It's not our dining program or our therapy program. It really becomes a part of our culture. Here I have an overview of the 5 elements of QAPI. These elements are your strategic framework for developing, implementing, and sustaining QAPI. Please keep in mind that your QAPI plan should address all 5 elements and that these elements are closely related. And we're going to find ourselves working on many of them all at once. They all may need attention at the same time because they all apply to the improvement initiatives that you may select. QAPI is to be based upon each facility's program and services and the particular needs of your resident and family population. So it's very unique to each facility. One QAPI plan will not fit all. Our discussion today is going to focus more around element 3, feedback, data systems, and monitoring. So what is data? We use that term a lot. And data is a collection of facts, such as numerical values or measurements. Data is anything that can be collected, tracked, reviewed, and is used for reasoning, discussion, or calculation. We are constantly collecting and tracking data, but it's not of value until we process it into information that will help us to answer the who, when, where, and what. Until we answer those questions, data is just numbers. Once we know these answers, we possess the knowledge to be able to apply data and information to answer the how and why. And that's the point we can begin to structure measures and make improvements. So I just put this little quote in here for us. This is from W. Edward Deming, the father of total quality management. And he says, you cannot manage what you don't measure. And that's kind of our little mantra for today's session. So looking at the element of feedback, data systems, and monitoring a little bit more closely. The purpose is to create a system so that facilities can take data and effectively manage or examine past or current performance and make decisions about what improvement efforts they want to undertake and structure measurement processes to determine if the improvement efforts are effective. So how do we make sense of all of this information? Where do we start? I had a colleague once say to me, we suffer from drip. And some of you may be familiar with that, but when she said it to me, I wasn't quite sure what she was talking about. But she said to me, we are data-rich, information poor. And I think we often can suffer from that in long-term care because we have so much sources for data and so much data that we track on a day-to-day basis. So where do we get started? Well, first, we need to make sure that we have a broad perspective of data sources. We often think of the publicly reported quality measures, CASPER reports, our standing audits, our clinical items such as med errors, falls, pressure ulcers. I think those come to us sort of automatically. But however, are you looking at your complaint system for data, your survey, satisfaction surveys, or our state survey and certification findings? All of these hold data sources for us. And take a look at chat. If you haven't kind of looked over at chat, we just had Teresa pose the questions for everyone out there, and just to get some conversation going about what are some of the data elements that you collect and from what sources? Because I know I've really just tipped the iceberg with this listing here. I also encourage you to give real thought to your data collection. It is important that you collect data that reflects the uniqueness of your organizations and services provided. Again, we are often guilty of collecting a set of data because we've always collected it. It just becomes standard. But are we really doing anything with that data? Is it necessary? Is it applicable to our current efforts that we're making? You may not always get the required data from one source. For example, you may need to pair satisfaction surveys with some sample audits. And then also I encourage you to really think about how you're presenting the data. How the data is presented can determine how it's received. Remember, QAPI is about the entire organization, not just a team of people. Also, it's important to remember that your data must be accurate, valid, reliable, and without bias. Again, I said that sometimes your data is not one size fits all. The way you collect your data is not one size fits all. You need to decide how you're going to capture the data, who will be assigned responsibility for collecting the data, and then who is assigned responsibility for monitoring the data. This slide here just provides, again, some ideas and some ways to collect the data, from tally sheets to chart audits, observations, interviews, and again, this is just a list of a few ideas to get you thinking. Then we use the data to identify gaps and opportunities. And ways to look at this is to look at trends, patterns, or variances. Trend is the general direction in which something tends to move. Easy one to kind of think of is, do we see a trend in pressure ulcers? Do we see a trend in pressure ulcers going up? Each month are we having more and more facility-acquired pressure ulcers? A pattern is consistent and reoccurring characteristic or trait that helps in the identification of a phenomenon or problem and serves as an indicator or model for predicting the future. Following the example of the pressure ulcers, do we see a pattern of pressure ulcers in the wintertime? Do we have a lower number of acquired pressure ulcers in the spring and summer months, but when we're heading into those colder months and we have residents who they don't want to get out of bed because they're cold, or we have more instances of flu. We have a flu outbreak during the fall and winter season. Do we see a pattern, a seasonal pattern to our pressure ulcers? And then a variance, a difference between what is expected and what actually occurred, any anomalies. So using your data, you have identified gaps and opportunities. Now you're ready to select a performance improvement project. Part of developing a project performance plan is setting measures. Remember that quote I just shared from Deming, what we can't manage, what we don't measure. The goal is to measure the effectiveness of intervention or action, not that the action was taken. You'll need to define the numerator and denominator. For example, if you're testing a change on one unit, your denominator would be only those residents on that unit and not the entire facility. Then define your sampling plan and time frame. As part of defining the time frame, you'll need to define your baseline period and related data. Utilizing the baseline knowledge, set a realistic threshold. It's also helpful to identify benchmarks. For example, if your facility is affiliated with a corporation, then you can maybe use your sister facility's performance as a benchmark. We also have, state and national numbers in our CASPER report for our quality measures. You could use those as state or national performance as benchmarks. There are different types of measures. We have outcome measures. Outcome measure is a measure which evaluates the result of an intervention. It assesses whether the change that you've put into place had the desired effect. And then we have process measures, a measure which evaluates whether something is happening as expected. and it is required in order to determine if the change in outcome was linked to an actual change in process. And then third, I have listed here structural measures. I think this is one that is sometimes missed. It's a measure that evaluates whether needed structure is in place and working well. So let's talk through some examples of these three measures. So an outcome measure, we just talked about pressure ulcers. So an outcome measure would be the number, whether you wanted to focus on your low-risk or high-risk residents that developed a facility-acquired pressure ulcer. And then a process measure is something focusing on a topic, again, has the process been implemented to facilitate change. So we have the process here example of the number of residents who had a grade and scale assessment completed within 24 hours of admission. And this measure is important because sometimes just by focusing on a measure, we can see improvement because we have raised awareness, but our system didn't really change. And if we don't validate that our process, that our system has changed, then we're not going to be able to sustain that improvement. And then finally is an example of structural measures. So again, continuing with the pressure ulcer example, we may have identified that we are going to switch over all of our mattresses and place them with pressure-reducing or pressure-relieving mattresses based upon the resident's assessment. So have those structural measures been taken? It's important that we're not merely collecting the data and reporting off. It's really more of the QA process that I think many of us are familiar with. It's important that we move forward with the data. We're going into football season and heading into the World Series, so I'm going to make a sports analogy here. Probably at some time we've all played on a team. At some point, we have to make the decision to play, to be a part of that team, to take action. It's easy to watch the data, but we need to get involved and take action. And all action will not result in a home run or a touchdown, but quality improvement measurement is for learning, meaning we need to collect enough data to help us learn, but not so much data that we end up with data fatigue. It's also important that we set a duration. And this duration of how long you collect the data is going to vary from project to project, but you want to make sure that you set a duration that's long enough to ensure sustainability. A good rule of thumb is approximately 6 months. And then your structure, make sure you have your structure measurement in place so that you know if real change has occurred. And then share the data. And I just want to also take a moment to point out, we've posed a chat question here. Pause a moment and bring your attention to that. You know, how do you share your data and with whom? One question that I'm curious about is, do you share that data with your families and residents? And if so, how is that done? So please, take some time to type that in, type in your answer to these questions. Or again, feel free at the end when we have opened the lines. If you want to comment on these questions, feel free. But like I said, I'm very curious about how we're engaging family and residents with data. So if anyone is doing that, would love to hear how that's being done. So transferring data into action. So one of the things, I'm going to transition here into our part of sharing the data of the Nursing Home Improvement Network with you. And how we've taken action as a collective team of nursing facilities across Maryland and Virginia. So I put here our aim as a Nursing Home Improvement Network. What are we all coming together to do? And it's to instill QI practices, eliminate healthcare-acquired conditions, and improve resident and family satisfaction in Maryland and Virginia nursing facilities. Oops, I advanced too fast, just a moment. And then just wanted to remind us all, we've set goals. We've set goals to decrease antipsychotic medication use, We've set goals to decrease potentially avoidable hospitalizations, decrease the prevalence of C. diff, and also improve quality measures using the National Nursing Home Composite Score. Today, I'm going to focus on sharing data around two of these measures, specifically decreasing the unnecessary use of antipsychotic medication and how we're improving quality measures using the composite score. So just again, I'm not going to read all of these to you, but I just wanted to remind the group of the composite score, what that's made up of. The National Nursing Home Composite Score is made up of 13 quality measures for long-stay residents, and that includes flu and pneumonia vaccine. And then those measures are calculated into a composite score, and the goal is to achieve a composite score of 6 or less. So how do we reach these goals? And what we did is we set up a collaborative approach, and in CHQC, we facilitate learning from both colleagues and experts. We create environments where we can share best practices, and we're going to get to that soon today. That's going to be the best part of this presentation, is hearing best practices from fellow nursing facilities. Peer mentoring and educational webinars and workshops, and again, sharing of improvement resources. We also are participating, as Maryland and Virginia, across the nation with other nursing facilities in other states in collaboratives. We're Collaborative 1 is actually just ending this month, and then our next collaborative is starting April 1st of 2017 to September 30th of 2018. And during those periods, that's when we are really doing some rapid cycle improvements with you all. So that's how we reach our goals. So what are our measurements? I've been preaching to you today to set measurements. So what's the measurements of the Nursing Home Improvement Network? So I said I'm just going to focus on two today. The first one is reduction in percentage of long-stay residents who receive antipsychotic medications in Maryland and Virginia. And we have a goal. Our first goal is to achieve a 3% relative improvement rate, or RIR, by March 31st, 2016. And then that grows year over year, as you can see. Our next goal is to 9%, then 15%, and then ultimately sustaining that 15% relative improvement rate until September of 2018. And then we also want to improve quality measures, improve that composite score measure. And we want to help 15% of facilities in each state achieve a composite score of 6 or less by March 31st of 2016. And then that grows. We want to achieve 25% by 2017, 45% by 2018, and then 50% by September of 2018. So let's take a look at how we're doing. So the first slide I have here is Maryland's antipsychotic medication reduction data. And you can see there I have noted for you, this is the medication rates percent of RIR from baseline, and our baseline for both Maryland and Virginia is Q1 2013 to Q4 2013. So 2013 is our baseline. So how much have we improved from 2013 to March of 2016? And remember, I put our goal down at the bottom for you. Our goal is a 3% relative improvement rate. Well, in Maryland, we have actually achieved a 16.5% relative improvement rate. So I just really appreciate all the facilities' hard work and focus on this issue. And as you can see, we have not only exceeded our goal for March 31st, we have exceeded our goal for the entire period of the network, and so now our goal will be to sustain these improvements. And then next slide is Virginia. and you can see Virginia's data here. Virginia nursing facilities actually achieved a 20.9% relative improvement rate. And you can see, I'm going to flip back to Maryland for just a moment. You can see that we actually had a little dip, but we're starting to trend back up, so that's kind of looking at the trends. And then also just point that out for Virginia, you can see that the trend, and this is a good trend. This is a relative improvement rate, so this doesn't mean that we're increasing the rates of antipsychotic medications. It means the rate at which we're making improvements. So again, in Virginia as well, our goal will now to be to sustain these efforts because we have exceeded even our greatest goal of 15% that we set. So thank you all for making the efforts that you have to reduce unnecessary antipsychotic medications, ensure that residents are on the right medications for the right diagnoses. And we have a facility today that is actually going to share how they've achieved some of their successes in reducing antipsychotic medications. So then I talked about the nursing home improvement network composite score data. So our goal, as I mentioned, was to help 15% of facilities in Maryland and 15% in Virginia achieve a composite score of 6 or less by March 31st, 2016. I will let you know, I talked about numerators and denominators earlier. The denominator for this measure is 169 nursing facilities in Maryland and 212 nursing facilities in Virginia. So we had set our goal for March 31st, 2016, so we can check in here and see that we met that goal in Maryland. We actually achieved 17.16%. And in Virginia, we were at 9.30%. So not quite there in Virginia. But however, you can see that we're progressing. As of August data, we have 27.81% of Maryland facilities achieving a composite score of 6 or less, and 15.56 in Virginia. Some things I want to note while you're looking at this is just a quick little orientation to your own composite score reports. Each month, the facilities are receiving their composite score report. So your individual nursing facility report looks very similar to this. This is aggregate data for the state, where we have the Nursing Home Improvement Network, notice it's NHIN. You would have your facility-specific data there. And then you would have the benchmark against the Virginia nursing facilities participating in the improvement network, the Maryland facilities participating in the network, and then each state at large. And that very last notation there, NNHQCC, that's the National Nursing Home Quality Care Collaborative. That's benchmarking across all of the nursing facilities that are working in this quality improvement initiative across the nation. You will also notice that we have some benchmarking holes. We have for the states and for the national data, you will see after May, you've got some blanks. That is because we do not have the validated data in just yet. Our data is validated through May for the state and at the national level. And then that data that is filled in there for June, July, and August is pulled from the facility capsule report. So that's just a little orientation to the composite score. You also see that you have trend lines. Also, we break it, not for the sake of time today, I did not do this, but you get this breakdown in your individual report per each quality measure. So you can see how you're performing on each of those 13 quality measures. One last little plug, and then I'll move on to the composite score data. We recently introduced a new format for you to receive your data. Rather than receiving the data via an encrypted email, we have begun to use a platform known as Box, and that's a secure platform. And you should have, your administrators and probably most of the director of nurses received an email introducing this new platform and also sending you an invitation to join Box. So if you have any questions about that, if you're an administrator or director of nurses on the line and you haven't received that, we've got our contact information on this presentation. Reach back out to us and we will get you that information. If you're not an administrator or DON but you want your data, touch base with your leadership team, get connected with us, and we can add you to that Box platform. We will send you an invitation and you can begin to access your data. So that's my commercial for composite score data. Also, on the composite score data, at the end of each individual report, you also get a sort of a kind of snapshot of all of the measures. It's the very last tab on your report spreadsheet, and it shows you at a glance what QMs are driving your data. And for us, driving your score. And for us as a network at large, and actually this is for both states. I thought each state would fall out differently, but they fall out the same. Our quality measures that are impacting the composite score overall for both states is incontinence, activities of daily living, and antipsychotic medications. So we've made great strides in antipsychotic medications. As you can see, we've had a lot of success there, but some opportunities still exist. And then I had also shared, when I was going through the agenda, that we were going to recognize some facilities that received the Nursing Home Improvement Network Quality Award. And we gave out awards focused on, again, antipsychotic medication use and around composite score. So first here, I'm going to let you all read the slides. I'm not going to read, again, for the sake of time, read all of these names to you. But I will pause a moment here and let you look through the slides. But this first award is for the top 5 nursing homes with the highest antipsychotic relative improvement rate from baseline of that 2013 year to quarter 3, 2015. And then our next award was the top 5 nursing homes with the lowest antipsychotic medication composite score from quarter 3, 2014 to quarter 3, 2015. I'm just going to pause a moment so you can read through those. And then our next award was the awards for composite score. Again, remember our goal was to help facilities achieve a composite score of 6 or less. And here listed for you are the Maryland nursing facilities that met a composite score of 6 or less at least once during quarter 3, 2014 to quarter 3, 2015. And then next, we'd like to recognize those Virginia nursing facilities that met a composite score of 6 or less at least once during, again, the same quarter, quarter 3, 2014 to quarter 3, 2015. And all of these nursing facilities received a award certificate that they could post in their facility. And we will be making these awards again next year. So more to come throughout this entire initiative. We will be having these quality awards. So congratulations to those, and more to come. We know we'll be adding more and more to this list. Before I move into the next section, Teresa, do you have any feedback in chat, anyone that has shared some of their data or measurement experiences in chat?
Yes, we do. We actually have Nicole Daniels from Solomon's Nursing Center that they share their data with employees in staff meetings. Also, certain improvement outcomes are shared with families and residents via resident and family council meetings, but they're always looking for more ideas. Trent Clugson from Mountain View also shared that they share their data with their frontline staff so that they can own the improvements and be more motivated with the new performance improvement projects. And he thought it was a nice idea to include families and residents. They're not formally doing that yet, but they do occasionally share antipsychotic data with potential residents and or families. So I thought that was great.
Okay. Well, thank you. And thank you all for sharing as well. So that's a nice segue into our next part of the presentation, and that is our sharing section. I'd like to introduce some very special guest speakers that we have today. And during the next portion of our presentation, we will be hearing from the Hebrew Home of Greater Washington, and with the Hebrew Home, we have presenting Neil White, Administrator, Jackie Vance, VP of Quality and Corporate Compliance, and Dr. Elise Gil Perez, VP of Medical Affairs for Charles E. Smith Life Communities. Then we also have Asbury Solomon's Island, Marie May, Director of Nursing, Falcon's Landing, Leanna Perez, Director of Nursing, and Mountain View, Trent Colston, Administrator. And as we go through these presentations, I'm going to let all of these individuals tell you a little bit about their facilities and their experiences with performance improvement plans and how they've used data and measurement to really show some great outcomes. So Neil, I'm going to turn the first story over to you and the Hebrew Home team.
Okay, well, thank you very much. Welcome, everybody. For those of you that don't know the Hebrew Home of Greater Washington, we are located between Bethesda and Rockville. We're a 556-bed facility with 99 post-acute care beds. We have a lot of interesting things going on. We're pretty excited about our quality programs, and so with that, I'm going to turn it over to Jackie, who is head of our QAPI approach, and she'll tell you a little bit about what's going on.
Thank you. Could I have the next slide, please? And the next one, sorry. There we go. So while this is popping up, it was nice. Sheila went over all of the elements of QAPI, so all I really want to say is that we have taken all of these elements and we incorporated them into all aspects of our program. And like Sheila said earlier, QAPI is truly a part of our culture and integrated into almost everything that we do. Next slide, please. I wanted to show you our structure. First of all, we have support from our board, and I'll go into a little bit about that when I get to the next slide. We have basically a monthly infection prevention and control committee meeting that's very clinical, and we also meet monthly because we are so large, like Neil mentioned. We have a QAPI committee meeting. We're showing you Landau House, which is also part of our structure. That's our assisted living building, but for the most part, I'm going to be talking about HHTW. Then you see we have a quarterly P&T committee. We have monthly medical staff meetings. And our utilization review meetings used to be weekly, but with the advent of Section GG, we have moved those up to 3 times a week. And at each of these meetings, data is reviewed, it's analyzed, it's measured, and then if you'll just hit the cursor, we'll have a little pop-up here. And then you'll notice that should there be a need, depending on that data that we reviewed, we will put a performance improvement program in place. Next slide. Our governing body, which is our board, is in charge and has given us a charter to have a quality improvement committee that is represented by different board members and members of the community. And I think the most important thing that I want to mention about this is that we're very lucky because our board assures that we have adequate resources to conduct an extremely robust QAPI program. And our board themselves foster a culture where quality is a priority. And that has, when you have that type of support, it's extremely helpful because when you're starting with that type of, with the board fostering that culture, it definitely spreads through the rest of the organization. Next slide, please. So I'll tell you a little bit about our program specifically. We have representation from all of the departments at our QAPI committee because we really discuss and look at data from all of the different departments. It is headed by myself, and like I said, we do hold meetings monthly. On our monthly agenda, for the most part, we review our internal measures for trending. We have an EMR, and we point click here. Most people who are at least somewhat familiar with that are familiar with that name. And we don't really care how we're comparing against other users of PCC. We set our benchmarks, and what we're really looking at is, are we meeting those benchmarks? Are we trending in the right direction? And then what we want to do is, can we predict where we're going to be when the quality measures emerge? Are we producing the results we want to see? So it's nice because we have our VHQC data monthly as well. So we also compare our internal numbers with the numbers that VHQC reports to us. We want to make sure that they are the same or close to the same. And because VHQC does use some different data sources. But then at that big quarterly meeting, what we do is look then at the CMS quality measure data, and that when Sheila showed you, they had May's basically it's a rolling data, just like our data is that we look at monthly, it's a 3-month rolling data, and then they have their quarterly results, and we look and see, are we there quarterly, and next time we do want to see, where are we measuring against other people? Do we need to adjust our benchmarks? Do we need to go back in and look at our PIPs or readjust our PIPs? And just very quickly, too, our PIPs follow the SAFER process, and that's where the S, we're selecting performance measures. This is where we say, okay, what data are we going to analyze? And then the A is we analyze that data. The F is where we're looking for opportunities for improvement. We're looking at root cause analysis. And then the E is we're executing our actions. We're putting that PIP into place. We set not only individual action steps, but what is the goal we want to meet? What date do we want to achieve those goals by? Who are the persons responsible for carrying out that particular action step? And then we reevaluate. That's the R. We reevaluate the performance at that reevaluation date. Are we there? Do we need to readjust, etc.? And next slide, please. And at this point, I'm going to turn this over to Dr. Phil.
Thank you, Jackie, and thank you, Neil, and welcome, everyone. The next set of slides, I'm going to take you through one of these current QAPI performance improvement programs that we currently are holding on our campus and are very much invested in. And the three we currently have committed to are readmissions rate reduction, antipsychotic medication reduction, and urinary tract infection rate reduction. Next slide. I'm going to take you through one of these, which is the antipsychotic medication utilization, not in a lot of detail, but just an overview. We identified this, as many skilled nursing facilities and long-term care centers have, as an area of concern many years ago, and anyone who's part of AGS or AMDA or any long-term care association knows that this has been top of mind for those of us who deal with the elderly for many, many years. Hebrew Home has always had lower rates than Maryland and the national averages, and we're lucky to maintain those. Antipsychotic Utilization Task Force. We started this back in January of 2016 when we realized that our numbers were starting to creep up a bit, and we brought together the medical department, the quality department, the nursing department, some administration, but also we included our partners, which are our psychiatric specialists, MedOptions, as well as our pharmacy provider, Omnicare, to look at this from an interdisciplinary viewpoint. And we implemented a performance improvement program around this, which included initial review of everyone in the facility who was getting an antipsychotic. One, to approve that the associated diagnosis was an approved one and was a valid one to justify that antipsychotic, but also to look at when the last GDR, or gradual dose reduction, had been done. How successful or unsuccessful was it? Was there adequate documentation documenting the success or the failure? And if it hadn't been done in a while, we asked our psychiatric and partners and our medical doctors to partner and really try to look at trying another GDR on that person. As a result, part of the PIP was to have a continuous review of all these residents and audit periodically the rate, but also the actions taken for these residents. Next slide. So our goal here was to reduce unnecessary antipsychotic usage and reassess every resident that was on these medications for justified use. Next slide. And so these were the components, some of the components of the PIP for this particular measure. New trials of GDRs were attempted. Non-pharmacologic interventions were really solidified as standard practice for all identified behaviors prior to the nurse calling the physician and requesting a medication for a certain behavior. And a lot of education and ongoing education at the unit level for the whole team on the unit about non-pharmacologic approaches to dementia with behavioral components. Next slide. And here's our data that we continue to analyze. And as I said, we instituted the task force and put this PIP into place around January of 2016. As you can see, we were approaching 17% rate of the antipsychotics at that point, and I believe Maryland at that time was in the low 20s. And so with all these measures in place and continuous effort and vigilance and a team approach, our latest data from July has gotten us down to about 9%. So for us, this PIP was definitely worthwhile and is a continuous effort that the whole team will be invested in. And I believe that's it for Hebrew Home's presentation.
All right, thank you, and thank you for sharing your data as well. We appreciate that. I'm going to open up the lines as I said earlier at the end. Save your questions for all of our presenters, and they will be available to answer any questions that you have at the end of the presentation. So moving on, I'm going to turn the presentation over to Maria with Asbury Solomon.
Hi, this is Maria Ame. I work at Asbury Healthcare on Solomon's Island. We're a very small facility with only 48 beds. And in March of 2015, my director of nursing brought to my attention that we had a very high fall rate for such a small community. You can change the slide. In March of 2015, we had logged 19 falls in 1 month. Initially, when we dove into the incident reports, we broke it down. There was 3 established categories: true falls, safe assist to the floors, or rolled out of bed to the mat. When we looked at the data, I wanted to determine where each fall was occurring. Was it a specific hallway, or maybe a specific GNA team? From there, we began to look more closely at the time of day and which shift the falls were occurring on. We looked at even more prevalent times, certainly during meals as well. What we discovered was that we had a high fall incidence around shift change. And we discovered that each team had multiple GNAs taking care of the residents over the course of 30 days. I had been attending shift change to see what the protocol was and found that the change of shift was a lengthy process, with very few associates remaining on the floor while a report was being given. This left our floor vulnerable, and the response time to call lights was found to be lengthy. After spending time with the nurses, the director of nursing incorporated the GNA to GNA walking rounds. This specifically was the off-going shift GNA and the current shift GNA together, putting eyes on each resident on their team and receiving a pass-down from the off-going GNA of any specific findings for the day. It was then offered to the full-time and part-time GNAs their choice of a permanent assignment by the director of nursing. In addition, we no longer required that the GNAs stay for the entire shift report, as they had a permanent team. Team 1 and 2 would go into the nurse's station and get reports from that nurse, always leaving 3 other GNAs on the floor. Team 3 would also receive report, again leaving 3 other GNAs on the floor at all times, and then Team 4 and 5 would come in and obtain their reports. This critical change gave each GNA autonomy to own their assignment. It provided a strong level of continuity of care to the resident, and it allowed the GNA to bond with the residents and to form a more deeper relationship with them. They began to really take pride in their team as they grew to know each resident on a more personal level. This increase in the quality of care, in turn, improved our quality measures, including pressure ulcers. The director of nursing was able to see a huge benefit in this practice. Our incidence of wounds dropped so drastically that we no longer needed to employ a wound physician. That's it.
Thank you, Maria. Appreciate you sharing as well, too. So next, we will hear from Leanna with Falcon Landing.
Hi, everyone.
I have.
Hello?
Yeah, Leanna, we can hear you. We're ready.
Okay.
Thank you.
Oh, sorry. My name is Leanna. I'm the Director of Nursing from Falcon Landing. We are a PCRC facility. We have 60 beds for nursing and 60 beds for assisted living. I'm going to talk about the long-stay UTI just to give you an idea. Last year of July 2015, we have on our composite score, we have 20%. As of June of 2016, we lowered our score at less than 6%. What we did, first of all, is we re-educated the staff regarding steady care, catheter care, hand washing, and also hydration. We initiated our hydration program, We include the dining department's activities. The dining department actually will stock the hydration cards, once a day with variety of fluids. The CNA offered this to all our residents as long as it's indicated. And then we make sure that our residents who have a catheter has appropriate diagnosis. We also use, on our QA program, we use the McGill criteria. I know you are all, you are familiar with the McGill criteria. This is a surveillance definition of infection in long-term care facilities. We make sure what we report on the QA matches what the MDS nurse put on her when she called the MDS. We also do hourly rounds. We just started our hourly rounds. And part of the hourly rounds actually is they ask the resident if they need to go to the restroom or use the restroom. In our facility, we do make rounds with our medical director twice a week. And we make rounds to all our residents in nursing and also assisted living. Assisted living is just once a week. Once a month. And of course, the MDS. The MDS should be coded properly. We make sure that those 4 criteria, the residents meet those 4 criteria, such as they need to have a diagnosis or from the doctor or nurse practitioner. There should be a documented signs and symptoms of UTI. Current medication or treatment of a UTI has occurred in the last 30 days. And there should be a significant laboratory finding exists. If one of these is missing, we don't code them as a UTI. And what I found is communication, because we do ask a lot of questions. How did she triggered for UTI? We involve also our rehab department. We do meet with them once a month. Make sure that we did not miss anybody. We are very active giving them the rehab screening. If there's anything that we see changes on residents, we involve rehab department. And of course, like what I said, communication is very important. Ask a lot of questions. And I think that's the main thing is asking a lot of questions. How did she trigger, not just UTI, but also our falls. That's one of the things that we're working now is reduction on our falls. I guess that's it.
Thank you, Lena. And that was nice that that's a focus of yours, that you followed Asbury. So I got some takeaways, maybe. Thank you. And now I'd like to introduce Trent and turn the presentation over to Trent.
Hi, everyone. It's a pleasure to be here and welcome each one. I just want to talk to you today about Mountain View a little bit. You can advance the slide, please. Mountain View is a small facility here in Central Virginia, 40 beds. We only do Medicaid certified. We do custodial care, maybe go through rehab. We're on CCRC. We're very small and compact here. We specialize in dementia care and the blight. So it's kind of who we are, and we believe that it's very individualized care and taking care of our staff. So we try to have a lot of involvement. I started out as a CNA here. Did my nursing, and then eventually came back as after some ER time as a nursing administrator. You can advance the slide again. So the project that I want to talk about today is waking our residents at night. But I wanted to talk about our team first, and a little bit of where Mountain View was when I came on board. Our team for this project was the director of nursing. We had a CNA supervisor and me. I was in the AIP program at the time with the former administrator here. what I found in the culture was that we really didn't utilize the interdisciplinary team here at Mountain View. We just kind of went with things as they came up, flew by the seat of our pants, I guess is how you would say that. And we only did the QAPI process because it became a requirement through CMS. And so we really weren't utilizing that. It wasn't our culture. So the issue that came up, if you can advance the slide again, please, was that we were waking the residents up too many times at night. We were also concerned about nighttime falls, UTIs, a couple of the things that we were working with. We were just trying to troubleshoot how we could work forward in that. I had a lot of leeway with my administrators to be involved with the clinical staff because of my background in clinical work. You can advance the slide again, please. So what we did is we implemented the use of the 8-hour nighttime brief. Don't currently have the actual brand of one to use if you're really interested in that. My contact information is at the end of the slideshow, and you can reach out to me. But the one that we used it contained a fiber that was supposed to neutralize the pH of urine to protect skin integrity and prevent UTIs. I was a bit skeptical because it goes against the old nursing model of turn and reposition and check every 2 to 3 hours. That's what we were kind of trying to get away from, and had a very progressive director of nursing services at the time. So we tried that. My concerns at the time were UTIs where the fibers actually work. We tried to treat. Also the smell of the facility. I didn't want our facility to start to smell like urine and things like that. And then also falls. Are we actually going to be able to increase the number of falls in our facility? So we can go ahead again.
Trent, I apologize to interrupt, but I'm gonna just to make a little housekeeping announcement. Again, I ask if people are not talking or asking a question that they just remember to please put their phones on mute. And Trent, I think if you could just speak a little louder as well too, that may help as well too. I think we may just have a little bit of interference, but if we have a little bit more volume, I think that would help. So sorry for the little 5-second housekeeping detail. I'm going to turn it back over.
Okay, sorry about that. I'll keep going here. Does that sound better?
Yes, thank you.
Okay, I moved the phone a little closer here, so we'll try this now. Sorry about that. So I was just talking about our concerns were will it really decrease UTIs? Will it really decrease nighttime falls? And then will it increase the smell in our facility to not change our residents for 6 to 8 hours when we implemented those nighttime briefs? So when we tracked this, we were tracking also behavior. That was a key that we wanted to see if it would also help some behavior issues we're experiencing. Nighttime falls, of course, UTIs, and then also pressure ulcers. Were some of the things we wanted to track with us. We wanted to make sure that we were protecting the resident's skin, UTIs, if they weren't falling, getting out of bed to use the restroom, etc. We can keep going ahead here again. So what were our results? So we did see a significant decrease in combative and agitated behavior. I'll just pull out one resident. I didn't bring a lot of data, real-time data here. I should have, but I did not when I was preparing this. But one resident that we noticed was a sweet old lady in a former life that had turned very combative, and I know each of you have seen that in your facilities. And we were really struggling to get to the bottom of it. Her family would hardly come visit because it wasn't who she had been before. So there was a lot of issues and dynamics involved in the family. And so she was part of our trial group when we tried the nighttime brief with a smaller group. And we noticed within about a week or so that her demeanor had dramatically changed from being combative to being more like she was used to, singing old hymns and being the lady that she had been in a former life. Very sweet. And her family started coming in and they started noticing a difference. And so, really, there was nothing else to chalk it up to except that she was able to sleep at night. What we found is that she was being awakened for rounds, and then she wouldn't be able to fall back to sleep for an hour. and then about an hour or so later she'd be woke back up again, and then she couldn't sleep for an hour. So she would get about a total of 3 or 4 hours of sleep at night, and, we're all probably pretty grouchy at that, so couldn't really blame her. And so we saw a great success, and that was an extreme example. There were other examples as well. We did see a decrease in UTIs. We saw a decrease in nighttime falls and in pressure ulcers. We were really hoping for results in behavior. We wanted to maintain our quality numbers in the other areas, and we wanted just to promote sleep as a way of improving the quality of life. But we weren't really looking for all the quality improvements that we actually did see with this project. We can go ahead again. So what did we learn as a facility? We did learn a lot about the healing properties and sound sleeping. Good sleep that follows through good sleep cycles. And also with this, like I mentioned earlier, we weren't doing well in the quality measures. It taught me a lot about the interdisciplinary team, working together with all the different departments here, whether it's activities or the social department or nursing or dietary. There's so many people have such a key role in what happens there with the residents, even though maybe it seems like the nursing should be front and center. Many of those other departments play such a key role. We can keep going here. So some positive outcomes that we saw. When we moved from a trial group then when we saw positive results to the majority of our residents that were with nighttime incontinence using this product. And we saw a lot of decreased behavior disturbances during the day. We saw more people being alert and interactive during the day. Currently, we're working with 0 UTIs in our facility of 40 residents for nearly 4 months, which is just phenomenal. We were off the charts. Our UTIs had gotten scrutiny from surveyors for the last couple of years in our infection control program, which we couldn't find any holes there, but we found it in other areas. We've had 0 pressure ulcers in our facility we did have for 6 months. I think we have one right now, but we've knocked them completely out after we had gone with this product. And we decreased nighttime falls since that implementation. So we've seen positive results in all these areas, even though we weren't even going for that necessarily. They were just things that came along with the project. We can continue going in this slideshow. There was a question on the format that they gave me about sustaining success, and I think that's very important because sometimes we reach a goal and then we move on to the next the performance project, and we kind of forget about what was going on and expect that to carry. You don't even know we have turnover and things like that. So one thing we've talked about with this is that we want to continually educate our staff on the product, why we use the product, and the proper use of the product. And we continue to educate them on the proper resident care. The other thing that we've done as administration is to provide adequate staffing so that each CNA has the time that they need to provide care. And that's just always tough because you can't make staff. They have to be willing to come work, but we try to promote an atmosphere where they want to come work. And then also another thing that we've done to sustain that success is to try to give each staff person a voice with further implementation, reviews of these products, problems, just in the whole QAPI process in general. We can go ahead and go forward again. And so just some things to consider that I threw in as my last slide, and then after this is just my contact information. Write a policy, and that's something my medical director really promoted to me when we were working through this. We need to back up our practice because it doesn't follow the traditional practice of checking your residents every 2 to 3 hours. And so we need to explain the rationale so that, you don't know who the surveyors are when they come, so that they understand the families, understand why you do what you do. I probably didn't include it under the educate often one, but families and staff need to be educated. They need to know why they're doing what they're doing, so they see the value in it, so they don't cheat on some of those things. They don't not do it, so they follow through. Include the staff more often in decision-making and these quality projects, to have their involvement, their voice. That gives them ownership that allows them to want to be a part of this. And then I think that kind of goes together with using interdisciplinary team. There's so much power in that, and something I'm learning as a fairly new administrator, really not even having been a nurse that is incredibly long. but just that power in your interdisciplinary team and in your staff, and know what's going on out there. That's all I have. Thank you.
Thank you, Trent, and thank you to all of you all from the Hebrew Home, Asbury, Solomon, and Falcon Landing. I appreciate all of our guest speakers today being so open and transparent in your sharing. So I'm going to ask our operator, Victoria, at this time, if she can please remind us how we can take our phones off of mute and ask questions to myself or any of our facilities that have presented, as well as you're welcome to post any questions that you may have in chat. So Victoria, I'll let you provide the instructions.
Thank you. If you would like to ask a question, please press star then 1 on your touchtone phone. If you wish to be removed from the queue, please press pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touchtone phone. And I am sure that there are no questions at this time.
Actually, I had a question for the Hebrew Home. When you all were implementing your project to reduce unnecessary antipsychotic medications, how was that received by the families? Did you find any challenges or pushback from the family members when you started out on that project?
Okay. Well, first of all, whenever there's any changes with the medication regimen, families are included so that they're aware. And occasionally a family would say, we don't want our mother or our father to have be put on a gradual dose reduction because we're afraid the behaviors will escalate. But we have a full-time medical staff here, and they're very well equipped to talk with the families and explain the benefits of getting off of these medications and putting other things in place such as recreation therapies / activities, working with the social work staff, working with the nursing staff to help redirect the behavior and improve the quality of their life. And we found that the families were, for the most part, very accepting of those recommendations. We worked also as an interdisciplinary team. It wasn't just a physician having to deal with the family. We had the nursing staff, we had the activities and recreation staff, we had the social work team all involved, supporting the family so that they knew what we were trying to accomplish was in the best interest of the resident, which is why I think we were able to have a successful outcome. I hope that answers your question.
It did. Thank you. But I also had another question that's maybe any of you all can answer, but I think I was thinking more of Maria with Asbury and Trent at Mountain View, since you all did some projects that really involved the nursing assistants, that very frontline staff. How did you all go about introducing this, so to speak, to the nursing assistants, and how did you, use them to implement it? If you could just speak more just how you kind of maybe got their buy-in to these two PIPs. Just for the sake of order, maybe Asbury, if you have any thoughts on that, I'll let you go first, and then Trent, if you want to chime in.
Yes, here for Asbury, I feel that the GNAs were very accepting of the permanent team assignment. It made the transition much easier for them to have a set group of residents that they were taking care of. There was definitely buy-in on their part. The walking rounds were a little bit more challenging in the sense that they enjoyed just walking down the hallway and having a conversation, not necessarily going into room to room, and that did take a little bit more time to really get them to accept that, but they definitely do that now.
Thank you. Trent, anything from your perspective with really help to get the buy-in from that direct care staff?
Yeah, I think one of the things we did was educate, again, on the importance of the product, on how to use it, on the rationale behind it. You know, sometimes we think that, well, if we've thought about it, if we've sat through meeting after meeting and we've discussed the pros and cons and sorted it all out, that everybody understands it the same way we do. Something I've had to learn early on in my career as an administrator, that you still have to educate them because they don't know. So we have a monthly staff meeting that's mandatory, and we have very good attendance. I think food helps that, actually. In that meeting, we spent a lot of time educating on the importance. And, of course, we did it as a trial group. You know, so it was a small handful of residents. I don't know, it may have been 4 or 5. I don't remember the exact number. And so it wasn't a huge group. It wasn't a huge change all at once. We did it gradually. And that gave them time to see it work, and especially that extreme case and some others, where by the time we went to a bigger group, they were much more accepting of that.
And a follow-up question for you, how was that received by your families as well? Because I would think, you know, families would maybe be concerned too about hygiene, if nothing else. If maybe they're not aware of pressure ulcers, they're aware of hygiene. So did you get any pushback from family members?
You know, we really did, and I wasn't as involved then with that interaction with the families. I think the director of nursing at that time was especially involved. So I don't know how she marketed that to the families, how she presented that, but she did a very good job at selling that as something that would work well. And so at this time, we have 0 questions, 0 pushback.
Thank you. And I have one last question for Leanna at Falcon's Landing. Leanna, you mentioned hourly rounds. Who makes those hourly rounds? Who goes on those rounds? We may have lost Leanna. That's okay.
Hello? Sorry, I heard it. Hourly rounds, actually, it involves CNA, nurses, and nursing management, not only for CNAs. We do rounds, and even supervisors, we do hourly rounds. And when we do our hourly rounds, we have to ask if they're in pain, make sure that all their personal belongings are in place or within reach, going to the bathroom, and there's another one. It's 4 P's that we actually ask. Can't remember the other P. Pain. I can send you positioning. Those are the 4 P's that we make sure when we make our rounds. We check all those things. And it will get...
Yeah. I was going to say thank you for bringing up the 4 P's because you all have shared that with us before, and I believe at VHGC we may have put it out there. I think that may be on our online community as well. But we'll double check and make sure those 4 P's is out there as a resource. And if anybody wants that, please reach out to Leanna or reach out to VHGC because they've been very gracious in sharing that with us. Victoria, I'm going to ask if you have anybody else on the line that might have some questions. If not, I think we'll move into our closing discussion.
We have no questions at this time.
Okay. All right. Well, we'll move into closing out our time together. While I'm just making some closing remarks, I'm going to ask Emily, our webinar host if she would open our polling questions for us. And the polling question is our evaluation. So again, we just ask that you take a few minutes and complete the evaluation. And we started off today with the question, the QAPI journey, are we there yet? So to answer our question, no. But we are on our way. QAPI is a journey, and along the way we'll have milestones to celebrate and lessons to learn. Thank you today for your time. I appreciate the opportunity to share your data with you as Nursing Home Improvement Network participants. I appreciate the sharing from the various nursing facilities today. Again, I appreciate your transparency. And I thank each of you and your team for dedication and endurance throughout this QAPI journey. And so again, just take time, pause a moment, fill out our evaluation, and please go back and give your thanks to your entire team for all the efforts they make in improving the nursing homes throughout Maryland, Virginia, which eventually leads to improvement throughout the nation. So thank you, and have a good afternoon.
Thank you, ladies and gentlemen. This concludes this class. Thank you for participating. You may now disconnect.